Hope everybody's good today. This'll do. Okie dokie. There you go. I've been studying for turn this on, so sorry if I seem a little tired. Already been at it. Kind of a little bit annoyed because the questions on the homework are actually different than the assigned reading. So that's fine. It's fine. Everything's fine. Okay, let's see. Should start our timer. Pew. Okay, so the next question we have here, or the first for you, I guess. An intraprocedural transesophageal echocardiogram is provided for a guidance during an LA appendage occluder procedure. Probably on the image provided would be current position, redeploy a device in current position, recapture device, move to a different position, or release the device in current position. I would move it to a different position because it looks like it's not actually occluding the entire appendage. Okay. Oh boy. Oh, that's an atrial appendage, but I don't know which one. Could be the right or the left. I think it's left. But I'm going to be honest, it looks like the coronary sinus. It doesn't even look... Oh, that's an option. Yeah, I bet that's the coronary sinus. Oh, you know what? So the textbook of clinical echocardiography. This is the textbook that cardiologists use when they're reading about this stuff. I'm not going to be a cardiologist. That's too much pressure for me. What I'm going into is pretty high pressure too, but not like that. It's also much more expensive. I need TEE views for this question. A short axis, I think. Maybe not. I wonder, there's the crab. I wonder if there's a graph with all of the planes. Okay, so that's a long axis. It sort of looks like this is the left atrium and the left ventricle. But just to really, the question's about, but I'm pretty sure it's just a bad picture of this. Oh. Okay. I'm gonna say it's because I think it's just the aorta looks big, because I'm pretty sure I can see the coronary sinus off of that. It was. Okay, there's that crab walk looking thing right there. Superior vena cava, inferior vena cava in the right atrium here. That's not. That's the left superior and the left inferior. And that's the left atrial appendage. What an so this tube is in your esophagus, and it goes down, and your stomach is like right about here. See, stomach, esophagus. So that's like it gives me a tummy ache. Okay. This actually looks a lot closer to what I was thinking I was looking. Not close enough. I think I'm going to stick with the left atrial appendage for this question. Yeah. It's very difficult to answer questions like this when the quality of picture is bad, but you work with what you have. Okay, let's see. 3D images are obtained in a patient undergoing a catheter-based valve intervention. The following image of the deployment catheter in the left atrium is obtained. The echolucent finding indicated by the arrow is consistent with what? Now, I would really like to find this image in the book. Excuse me. Great. Arteries. All right, so our choices are stitch art, acoustic shadowing, micro bubbles, or vegetation. I bet this picture is in all right, well, let's knock out which ones we know it's not. It's not stitch artifact. I don't think it's micro bubbles. I don't think it's acoustic shadowing. I think it's vegetation. Is what I think it is. Let's see if we can find the picture though. Some of these pictures are so neat, but none of them are helpful right now. I was just gonna say it's kind of mean to give us 80 page exaggerative, over 80 pages of and the homework questions reference none of it directly. Rude. Let's see. It's got to be in some of the extra stuff. Oh, I wonder if it is. Those are always so interesting. Since I'm looking through something else, I'll put that up on the screen. See if I can manage to do that on the fly. Maybe. Maybe not. Yeah, I might have to prep that later, next time. Part of the problem with not having direct, like, one-to-one references is I get caught up in looking at all of the other things. Got too much homework to get distracted, and yet it happens constantly. I think probably helps me learn though, so there's that at least. I'm gonna have to read through all this later. It's too interesting not to. Optional. Why is the optional reading always the most interesting? All right. I mean, it could be micro bubbles. It's bubble shaped. I'd ask the group. I don't think anybody else is working on this yet. She put a quizzes in there. That's nice. Okay. Well, we're just gonna be psychic. Use his big old brains. All right. So, what angle? That's at a 45. So 45 degree. It should be in one of these tables. Okay, so echocardiography image plane starting from 4-chamber view with the left ventricle apex centered in the image allows 2-chamber view at approximately 60 degrees of rotation and long axis view at 120. And this says it is at 45. I think that's bubbles. Because that does not look like a valve. Four chamber is 0 degrees. Unless they don't look small enough to be micro bubbles. Maybe there are a lot of micro bubbles and it makes it look like they're bigger. Oh my gosh. Okay, this Doppler tracing recording during the intraoperative TEE shows what? Oh, okay. So it's pulse wave 3.5 megahertz, and it's about 0.5 toward and about 1 away. Some of those waves kind of look like the mitral valve. I think I think that looks like it's between the mitral valve and the aortic valve. Let's take a look at our options. Superior vena cava flow, pulmonary vein flow, coronary artery flow, atrial flutter, atrial fibrillation. Oh. Our EKG looks bad. That looks like an atrial flutter to me. That makes sense. That's why it's going back and forth instead of one direction. Oof. Okay, that one wasn't too bad. You perform a TEE study on a patient who is under evaluation for mitral valve replacement. Cardiac anesthesia is bedside, and that's a little loud. Quiet down, fish. Okay. Cardiac anesthesia is at bedside bluffing. The probe cannot be advanced beyond 10 centimeters. Which of the following is the next step? Withdrawal, probe, and reattempt placement. I would say that's probably it. Rotate probe clockwise and retroflex probe tip. Nope. Increase sedation. No. Just take it out. Turn it off and on again. 64-year-old man is referred for a coronary artery bypass grafting surgery. He has a history of prior cardiac surgery. During this procedure, the following image was obtained. You conclude that what? Aortic valve replacement, mitral valve anesthesia, coronary artery bypass graft surgery, LA appendage occlusion procedure. Patient with rheumatic mitral valve disease is referred for mitral valve procedure TEE. The following images are obtained. Tracing the mitral inflow Doppler signal provides diastolic mean gradient of 9 millimeters mercury and a heart rate of 73 beats per minute. What additional imaging is needed prior to the valvuloplasty procedure? Good heart rate. Mitral inflow diastolic is at 9. Okay. TEE is not my biggest strength, but it's super necessary to get better at it. All right. What is that? This looks familiar. I think this might be in my workbook. One of them. All right. Well, it's not my workbook. Lame. This still does look very familiar, though. What additional image do we need? In addition to... Looks like that's a continuous wave of the mitral valve. And that's a... I don't know what that is. That might be a pulse wave in the mitral valve. Well, we need planimetry of the valve. All right, so our choices are 3D atrial septum, of the mitral regurgitation. Now we've got that already. Estimate of mitral valve area using pressure half-time. I mean, I guess. Planimetry of the mitral valve orifice area. Let's pick that one. Presents to the emergency department with acute, severe chest and upper back pain and was diagnosed with acute type A aortic dissection. Transthoracic imaging obtained in the emergency department and an intraoperative procedure is shown. The patient has undergone aortic root replacement with mechanical bioprosthetic aortic valve replacement, resuspension of aortic valve, or transcatheter aortic valve implantation. Okay, this one. This makes me feel like I'm in the wrong chapter. Answering these questions, but I feel like I'm in the wrong chapter. Table 3-4 is the transesophageal views for evaluation of cardiac chambers, great vessel, or earlier. That's good to know. It's on page 94. Okay. Good to know for later. For now, we have another question. I was in the wrong chapter. I was in the wrong chapter. That's really funny. Okay, well, that means that after we get this done, I can actually check my answers. Amazing. I knew this looked familiar, though. I was like, I've seen this. I've looked at this, but yes, no, that is really funny. Oh my gosh. Dum 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 dum. Let's go back and take a look. Let's see how smart I hope I am. Okay, let's see here. Okay, during a waiting cardiopulmonary bypass, the patient undergoing following image was obtained. Let's. And I said it's about to get very embarrassing. Maybe not a good category to get found in. Co-working and studying better. I mean, yeah, you're probably right about that. Didn't really think about that. Especially since I'm not using the music for this thing. I just like the ferret. No, that's true. Yeah. You know, when I first opened this up, I was thinking I would, but so far I haven't at all. So maybe I'll just switch it over. I hadn't really thought about that. I appreciate you calling attention to that. Here. Edit stream info. There we go. Yeah, I'll change it to co-work. There we go. Do it then. Oh yeah. I usually just go for pretty basic tags. Like chill, study, etc. But I never really thought to put woman. Damn. Just never really thought about that as a perk. Okay. Yeah. No, that's true. I'm too literal, I think, sometimes. Okay, let's see how smart I am at this stuff. My first question was asking about an echo, and I picked artifact. Let's see if I was right. Oh, it is micro bubbles. No, that was for a different one, though. Was that for one? Okay. Well, that would be an artifact then. No, no, it wouldn't be an artifact. It would be bubbles. Oh, it's intracardiac air. Hence the bubbles. Okay, well, not looking too good. So far, the first question I attempted, I got incorrect. That's okay. All right, let's, the next one. An intraatrial procedure, transesophageal echocardiogram, is provided for guidance during an LA appendage occluder. And I said that the picture looked like it wasn't put there correctly. So recapture device and move to a different position. Let's see what the book said. Question 2. From the current position. Well, let's read the explanation for that because I'm not really sure what the difference is from the choice that I made. Okay, so the left atrial appendage occluder is well seated in the left atrial appendage. Okay. The mosaic is not for the left atrial appendage. The mosaic is for the mitral valve. Okay. It's really close. It looks like it's the same thing. The left atrial appendage measuring about 2 centimeters in diameter, the tissue ridge between the LA appendage and the left upper pulmonary, the upper portion of the image is, okay, so that's the upper pulmonary vein. These TEE views are so confusing. If it was a TTE view, I'd be on it, but the TEE views I don't really have yet. We'll get it. Now, between the device and the tissue ridge, there's a gap along the device about 4 millimeters in diameter. That is the appendage. Redeployment in the current position allows for an apposition of the device to the entire LA appendage, now measuring 2.4 centimeters in diameter at the view. The catheter that is used to deploy the device is still attached to the mid portion of the device, so recapturing is not needed. The device should not be released in the current position because of the residual gap in place. I don't see how you can determine whether or not it's still attached. Maybe that just wasn't. Didn't hurt steak is bad, but kind of don't believe it. Now I know why. High heat cooking makes glycation sugar bond to protein. Few seem to know meats are seldom or rarely boiled. Yeah, that's funny. What I forget what the what that term is. You put it in a bag, sous vide. Sous vide steak and just like searing it apparently is very very good for you. Like it's easier to digest. It's very good too. It's usually pretty tender. Yeah, sous vide. Yeah, it's pretty good. My dad got the Indian things, and every once in a while, I'll get a steak. He's gotten quite skilled, so I don't get good enough cuts of steak to do that. Usually, I'll do a roast. I'll do like a slow cook situation. Yeah. Well, he's very safe. He knows a lot about safe cooking temperatures. He was I don't know what his title was. He's retired now, but he was in charge of safety things for a long time. So he's pretty good about that stuff. Yeah. Cat parasite. That's a fun one. Okay. So I said left atrial appendage for this one. Let's see what we got for that. Left main coronary artery. God bless. I could not find a picture of that for anything. And also, to be fair, the right main coronary artery, you can't even hardly see it. It was the left atrium, and that was the aorta below it, but that's the aortic valve. You can't see any of the cusps. It's just a hole because it's the root and it's too high. Ugh. Okay. Image obtained in a patient undergoing catheter-based valve. The following image of the deployment catheter in the LA is obtained. Echolucent findings indicated by the arrow consistent with, I said microbubbles, but it might be vegetation. Let's see what the book says. It's acoustic shadowing. To be fair, we just started 3D to that because we literally just had the lecture like 2 hours ago. So some might argue that it should be fresh in my mind, but as much as I love my professors, that was one of the most boring lectures I've ever heard in my life. I was so... Yeah, I don't know too much about that. Well, this is studying for my echocardiography. I don't know if you can actually see this. Where's my thumbnail? This is what we're doing. And I wish I had these pictures of the questions that I'm working on while I do this, but that's a whole bag of kittens. So. No, not nursing. This is for echocardiography. So when I get done, I'm going to be doing ultrasound on the heart, and assisting with surgeries, doing imaging, guiding imaging for that. Maybe I'll get into cath lab. I'm not sure. I don't know if I want to do that or not. But so aortic stenosis, which is the narrowing of your aortic valve right there, the biggest artery in your whole body. It's where the blood gets pumped out of your heart into the rest of your body, right? That is like the biggest as far as heart disease goes, and it is so avoidable. The issue is that it's not found in time. It's not treated because you can't see in there on a day-to-day basis, but you can get it very quickly, very easily. And your recovery time is super fast, like for heart adjustments, you know? So it's one of those things where it's like, I want to make sure that people are, healthy and happy and able to live, that they like to do with their lives. So, yeah, you can get, why would it narrow? Calcification. You can get there's a lot of reasons. I think the biggest reason is rheumatoid fever. So if you have strep, the virus can actually cause it to narrow. That can happen to all of the valves in your heart. But there's that. There's been a huge, there's been a huge increase in young people having problems with their hearts because of COVID, because it is destroy your heart. A lot of people don't realize that viruses are extremely destructive to your muscle tissue, and so that's one of those things. A lot of people are in their bodies are basically older now since COVID. They might feel okay, but it's like doing donuts in a parking lot. Your tires are never quite the same, you know? Yeah. Also, if you have a blood disease, if you've got a bacterial infection, like sepsis, can cause vegetation growth on your valves, but that causes more than just stenosis. That can cause regurgitation, prolapse, all kinds of stuff too. You can get a stroke from that stuff. Yep. Yeah. Yeah, it was that virus, honestly. So, and also don't do drugs, because that'll turn your heart into Swiss cheese if you do, and that's pretty rough too. And yes, yeah, proper contraction, your blood flow isn't as it doesn't keep moving, and so that can cause thrombus, like blood clots, and those can break off and go straight to your brain, and that's how you get a stroke. Yeah. So, but if you can catch it early, you can stop those things from happening. So sometimes. Okay, now let's see if I was correct about this being an atrial flutter. What number is that? Number 5. Is it a flutter? Yay, I was right. I got one of them right. But that's because I know what a pulse wave looks like. And EKG, right? You perform a TEE study on a patient who is under evaluation for mitral valve replacement. Cardiac anesthesia is bedside and conscious sedation is administered. The probe is advanced through the bite block and oropharynx. The patient is agitated and coughing. The probe can't be advanced. Okay, that's a withdrawal. Okay, so B, yes, that was correct too. Good, good, good. Okay, 64-year-old man is referred for a coronary artery bypass grafting surgery. He has a history of prior cardiac surgery. During his procedure, the following image was obtained. You conclude that his prior procedure was, and I think it was an aortic. Let's see what the book says. Okay. We are looking. Question 7D. Ha! I was right. Look at that. 3 in a row. Looking good. Very nice. That looks like a bio replacement too. Okay, let's see. We've got our waveforms. For this one, we need planimetry of the mitral valve orifice area. Okay, and that is going to be C. So question 8. Oh, that one's wrong. What do they say? B. The images provided are consistent with severe mitral regurgitation as the dominant valve lesion rather than stenosis. That's a super... Okay. Full quantification of mitral regurgitation severity is indicated. The mitral inflow Doppler tracing shows an elevated peak early E wave velocity over 2.3 meters per second slope, which is bad. Not consistent with severe stenosis. The image on the right is Doppler tracing of the right upper pulmonary vein from the bicaval view, showing the systolic flow reversal. Okay. Planimetry of the mitral valve area may be helpful in determining stenosis severity, but with significant regurgitation, the patient is not a candidate for valvuloplasty. Oh, that's why it was wrong. So if he didn't have the regurgitation, he could do the valvuloplasty, but since he has regurgitation, he doesn't qualify. You have to do something different for him. When performed, the planimetry is relatively hemodynamically independent assessment of mitral valve area, smallest area of the relatively funnel-shaped orifice. Pressure half time is the time for peak pressure gradient between the left atrium and the left ventricle to reach half of its value, but which is elevated in this case, greater than 2.3 meters per second due to the regurgitation. Pressure half time will be shortened if the left ventricle diastolic pressure rises faster than expected, falls faster than expected, non-compliant left atrium. Okay, that makes sense. Yeah, any of that stuff. I mean, regardless how you intake it, it's like, even if she survived for, let's say, 30 years doing that stuff, because of those behaviors, because of those poisons, bonkers, absolutely crazy. Like all that stuff, it's the quality of life after doing that, like active psychosis that can happen because of it. It's wild. It's not just like, oh, you die. No, it's like your quality of life significantly diminishes and then you die. It is a trap. So for this vegetation, yeah, okay. All right, the next one. A 58-year-old presents to the emergency department with acute severe chest and upper back pain. He was diagnosed with acute type A aortic dissection. Okay, so chest and upper back pain. So which kind is that? Like a month ago. Let's see if I can remember it. Okay, so if it's just the arch, and if it starts in the chest and goes up to the back, it starts at the root. I want to say that is 1. That is what I think. I might be wrong, but that's not what the question's asking us. That's just a bonus. Let's see. Oh, acute type A to aortic dissection. I read that and completely forgot that I had read it, and then talked like cool. Okay, well there's types. There's A, B, and then there's types. No, there's types 1, 2, and 3. And 1, 2, and 3 is 1A, and then 2 and 3 are type B, I believe. But there's 2 qualifications. There's two qualifications. There's Stanford, and then there's and that's the A. That's the AB is the Stanford, and then the other one is the 1, 2, 3. But the 2 and 3 are type B. Anyway, none of this makes any sense to anyone. I'm sorry. Patient had undergone aortic replacement with what? Oh, and that's the question we landed on when I found out that I was in the wrong chapter. Okay, we're good. You don't usually have success from those things. But it's really cool when you do. Yeah. Mechanical aortic valve replacement, bioprosthetic aortic valve replacement, resuspension of aortic valve, or transcatheter aortic valve implantation. Any echoes in here, like hyperechoic areas? I'm not seeing anything like because usually you get like the white streak echoes. Not the time to share them. The American prison system is just slavery. That's all it is. It's the prisons are for profit here. So the people that run the police make the rules, put the people in the prisons, and then they work for, less than slave labor in other countries. So it's a mess. It's not a good place to go when you're trying to get better. It's not a good place to go regardless. So I guess I did share the opinions here. Yeah. Okay, so we're thinking bioprosthetic or resuspension, I guess. Okay, so it's a resuspension. Let's see why it is not bioprosthetic. An image shows a normal appearing aortic valve with thin leaflets and without supporting struts or sewing ring to suggest either mechanical or stented bioprosthetic. It is, oh, okay. So what about unstented? It's just assumed that it's going to be stented. I don't think they do unstented anymore, so maybe that's what it is. Okay. Transcatheter bioprosthetic valve, echo densities along the aortic wall from the valve cage would be seen. Okay, so we would still get hyperechoic spots in there. With aortic dissection, aortic regurgitation may be due to an intrinsic anatomic abnormality, such as a bicuspid aortic valve, or may be due to extension of the dissection into the base aortic valve. In this case, the aortic regurgitation was due to the prolapse of dissected segment through the normal trileaflet aortic valve. The prolapsing tissue impeded leaflet coaptation, resulting in severe restored normal aortic leaflet closure. Thus, the aortic valve was resuspended with only mild regurgitation post-operatively. I'm going to be honest, I only understood like probably about 75% of that because this is not an operation that I'm actually familiar with. I don't think we've gone over that one at all. So I think I understand why it's not a bioprosthetic replacement though, so that's good. What echocardiographic feature is most concerning to result in paravalvular regurgitation post-transcatheter aortic valve replacement? I gotta read that again. What echocardiographic feature is most concerning to result in paravalvular regurgitation post-transcatheter aortic valve replacement? I don't understand that question. Maybe it was written incorrectly. Maybe I'll understand it better when I read the possibilities. Maximal annular diameter of the aortic valve, increased of coronary oscillation of the left ventricular outflow tract. I don't have a freaking clue. I have no idea. Options available. I don't understand any of that. I know what the words mean, but I don't know what they mean in that order. All right, let's go. Let's go word for word here. Oh my God. Cardiographic feature. All right, so that is a feature of the Cineloop or picture or whatever that you get. Most concerning. All right. I don't know what that means. Okay, so paravalvular post-transcatheter aortic valve replacement. So that's a post-TAVR. What echocardiographic feature is most concerning to result? Okay, so what's the worst case scenario that could result in a paravalvular regurgitation for the post-transcatheter aortic valve replacement? Oh, I think I got it. Okay, so what is the worst case scenario in which you replace the aortic valve and it spits out the side? Maximal annular diameter of the aortic valve. Okay, so it's too big. Angulation. Okay, so it's off kilter. Height of coronary ostia relative to the aortic valve. I don't think so. Calcification of the left ventricular outflow tract. I'm going to say increased angulation. So if it's like going off kilter, I feel like that's the worst. Calcification is bad, but I think that's probably the worst. So let's see what the book says. Oh, calcification is the worst. Okay. I'm gonna trust it. How many questions we got left here? 2. All right, cool. Almost 6 o'clock. I'll have this done, so that's good. I've got several projects left, but having this out of the way is good. A patient with severe mitral regurgitation is referred to for percutaneous edge-to-edge repair. TEE is utilized to provide intraprocedural guidance, and systolic imaging is obtained. The most likely etiology and location of the mitral regurgitation is the what? anterior leaflet, medial scallop, anterior leaflet, lateral scallop, posterior leaflet, medial scallop, posterior leaflet, lateral scallop. All right, well, let's take a look at this thing. Let's say anterior. I'm going to say anterior medial. I need to memorize those leaflets. All right. I was right. Awesome. That's cool. All right. Intra-EE is obtained in a patient during transeptal puncture for percutaneous edge-to-edge repair procedure. Based on the image obtained, what additional procedure do you anticipate after completion of the percutaneous edge-to-edge repair? Don't know how to interpret 3D imaging well enough to know. I mean, probably a septal defect closure, because it looks like they're going through the interatrial septum to do it. All right, our options: closure, no additional procedure, pericardiocentesis procedure, left atrial. All right, yeah, I'm pretty sure it's a atrial septal defect closer. So that's B. Let's see. Ooh, I was wrong, and it has a graph because it is complicated. Okay, so the 3D image obtained during the transeptal puncture, the catheter is seen crossing the interatrial septum. As is the case with any ultrasound imaging, an ultrasound beam cannot penetrate through the catheter. And there is an acoustic shadow. Oh, that's why it looks like there's a tear, because of the acoustic shadow. That makes sense. Okay. This should not be multiple imaging windows. Will demonstrate the absence of a large defect. Pericardial space is not visualized in this closed view, and determination of need for pericardiocentesis cannot be made. Similarly, the LA appendage not visualized in this view. So our answer is no additional procedure necessary. That's it. That's our homework for this specific class, not counting studying for the quiz. Thanks for hanging out. Oh, I guess I should submit this. Let's see what we got. Submit test. 97.3. What did I get wrong? Aww. That's lame. I suppose two were too fast. I wasn't paying attention. Lame. Well, hey. Can't win them all. 97's not too bad. That's respect. Yeah. All right. Well, I guess I'm gonna hop off of here and eat some dinner and then continue on my... I don't think I'm going to come on here for that because it's depressing. I mean, obviously, this is job things, but I don't want to depress everyone else. So, well,